Hey, this is Alyssa, Critical Care Pharmacy resident. Today, I'll be sharing with you the results of my year-long residency research project, which looked at the continuation of quetiapine after it was initiated in the ICU for an acute indication. As you all know, delirium and sleep disruption are extremely prevalent in critically ill patients, and oftentimes, because of the deleterious effects of both delirium and sleep, we attempt to use medications to mitigate these. Quetiapine is an atypical antipsychotic, and of the antipsychotic class, it's the one that we most commonly use for acute delirium or insomnia within Monument Health. Previous studies have, however, identified a little bit of a concerning trend, and that is that when we start antipsychotics in the ICU, we're finding that they're often continued after ICU and hospital discharge. So there is some concern that this could potentially represent inadvertent and/or inappropriate prescribing of antipsychotics. So because of this trend, the objective of my research was to look at our utilization of quetiapine when we started in the ICU. So I sought to determine the incidence of quetiapine continuation upon both ICU and hospital discharge among patients who are newly started on the medication in the ICU. I also looked at secondary objectives, and these were among patients who were continued on quetiapine upon hospital discharge, in which case I evaluated the indication if one was documented for quetiapine continuation. And then I also looked to identify factors that were associated with the continuation of quetiapine at hospital discharge. This was a single center retrospective study, and it was approved by our institutional review board. I included adult patients who were admitted between the dates listed and who received at least one dose of quetiapine while they were in the ICU. I excluded patients who were already taking an antipsychotic prior to admission, or when the patient had an alternative and FDA labeled indication for quetiapine, which might include something like bipolar disorder or schizophrenia, and then also patients who died during their hospitalization. On this figure, you can see I reviewed 373 patients for eligibility. After applying the inclusion-exclusion criteria, I ultimately ended up with 200 patients who were able to be included in my analysis. Here you can see the characteristics of the patients who were included in this study. My average patient age was 62 years old, and of my patients, about 2/3 were male. It is notable to point out that a substantial number of these patients did have an underlying psychiatric comorbidity, particularly alcohol use disorder and tobacco use disorder were common. My average length of stay for ICU was about 10 days versus hospital was about 14 days. 60% of patients were mechanically ventilated at some point during their admission. And then I also did look at the positive CAM ICU to try and assess whether our patients in this study were delirious. In order to do so, I looked to see if there was a positive CAM ICU documented within 24 hours before starting quetiapine, and then again to see if there was any positive CAM ICU documented within 24 hours prior to discharge from the ICU. So I found that 50% of patients had a positive CAM ICU within the 24 hours before quetiapine was started, and within 24 hours of leaving the ICU, that number had fallen to about 30%. The intensivist was the attending provider in about 2/3 of these patients, and then when patients discharged, most of them went to a healthcare facility of some sort, whereas 1/3 of patients went home. On the right-hand side, you can see the information with regard to the quetiapine regimen. So the average amount of quetiapine per dose was just short of 50 milligrams, and the median cumulative dose was 175 milligrams. So that would be the overall dose that the patient received during their hospitalization, and the median number of doses overall was 4. 90% of my patients received quetiapine on a scheduled basis, whereas 10% had it ordered only on an as-needed basis. The results of my primary outcome are listed here. I found that 69.5% of patients who were started on quetiapine were continued on the medication when they left the ICU and went up to the floor. I had 118 patients in this group. The reason I did not have 200 was because the remainder of patients actually discharged from the hospital directly from the ICU. So in those cases, the transfer to the floor was not applicable. At hospital discharge, 34.5% of patients were prescribed quetiapine. Of the 69 patients who were discharged from the hospital on quetiapine, the most commonly cited indications were agitation in 33%, followed by delirium and sleep in 15 and 13% respectively. I wasn't able to find any documented indication in 35% of patients, however. Here you can see the factors that I evaluated for their association with quetiapine continuation upon hospital discharge. The main factor that I identified was discharge to a healthcare facility, which had an odds ratio of 6.8. So patients were 6.8 times more likely to be discharged on quetiapine if they were going to a healthcare facility versus if they were going home. Male patients were also more likely, as were patients who received multiple antipsychotic medications. So, for example, patients who are also getting Haldol, patients who were also receiving a benzodiazepine, which oftentimes this was CWA protocol for our alcoholic patients, and then a positive CAM ICU before leaving the ICU, which I think that's kind of common sense. If the patient was still appearing to be delirious, it might make more sense to continue the medication. Patients who had a longer ICU stay were also slightly more likely to be continued on quetiapine at discharge. Interestingly, for patients who had the intensivist as their attending provider, or patients who were discharged directly from the ICU, they were actually less likely to be continued on quetiapine. Patients with an age of 65 or older were also less likely to be continued on quetiapine. This was not necessarily something that I expected to find, as previous studies have actually found that elderly patients were more likely to be continued on quetiapine. So in summary, 69.5% of patients continued on quetiapine when they went up to the floor, and 34.5% continued on quetiapine at hospital discharge. The most common indications for quetiapine continuation were agitation, delirium, and insomnia, although the indication was unknown in 35%. So there is some potential that in those cases, perhaps quetiapine was being overlooked when it was continued at hospital discharge. Several factors were also found to be associated with quetiapine continuation. The really big ones that I want to point out are discharge to a healthcare facility, having a positive CAM ICU before leaving the ICU, and then male gender. Ultimately, quetiapine was continued in a substantial percentage of the patients in my study, and certainly more than I had anticipated when I took on this project. Among patients who were continued, again, over a third had no documented indication. So I think there is perhaps some room for improvement with documenting the indication if there is one, and also just simply reevaluating whether the patient still needs to be on quetiapine and really questioning when we see that on a patient's medication list why the patient is on it and if it was something that they had been on previously or something that we started in the hospital setting. There are several limitations in my study. First and foremost, it was retrospective, so I could only go off of what I could find in the electronic medical record, and I was relying on that information to be both complete and accurate. My study also didn't assess the appropriateness of quetiapine therapy. I tried to look at the indication as kind of a surrogate marker, but truthfully, the two are not one and the same. There could certainly be instances where you don't have a documented indication, but it might have been continued appropriately or out of necessity. And likewise, there could be situations where there was an indication documented, but maybe the patient didn't necessarily need that medication. I also didn't follow up with patients after hospital discharge, so I have no way of knowing once these patients left if they were being weaned off of the medication or how long the quetiapine was being continued. And likewise, I wasn't able to look at important clinical outcomes. One of the reasons we try to get quetiapine discontinued when possible is to avoid polypharmacy, to avoid sedation, falls, particularly in the elderly, and then also the potential for QTC prolongation and arrhythmias with quetiapine. So, although all of these are potential risks, my study does not have the data to actually prove that continuing quetiapine is harmful. That wraps up my overview of my research project. If you do have further questions or points that you'd like me to clarify, certainly feel free to reach out to me. And also, thank you for listening.